we thought that we will pick up the topic of gallbladder cancer, which though uncommon in the Western world, is one of the commonest cancers in North India. In fact, in women in North India, other than the gender-related organs, that is breast, cervix, and ovary, gallbladder is the commonest cancer. And out of that also we picked up the theme of, or the topic of incidental gallbladder cancer, because that is the cancer which is eminently treatable, potentially curable, but often neglected or not properly treated. So we thought that it is the need of the hour that we discuss and then formulate guidelines for proper and appropriate and timely management of incidental gallbladder cancer, so that these patients who usually have an early cancer are receiving proper treatment. The format actually initially when we thought was of a core group meeting which will develop a clinical consensus statement. We couldn't say guidelines because there is very little high quality evidence on this topic. So the idea was to develop clinical consensus statements on various aspects related to incidental gallbladder cancer. And with that idea in mind, we selected a group of young faculty colleagues from India. So about 50 of them volunteered immediately and said yes, who were then asked to generate questions related to the topic of incidental gallbladder cancer. And these questions were then collated and crystallized into a set of 25 questions. And then a group of young faculty members were given the responsibility to review the literature on each question allotted to them. And the group was enlarged to include some senior faculty colleagues from India and from outside India, those who are in the field of HPB surgery. We also approached members of IASGO and through personal contacts. And then for each question, we could create a group of 4 to 7 or 8 mix of young and senior faculty members who were assigned one question each. So all the young faculty colleagues, they have done an extensive review of the subject, and that review has been sent to all the senior authors, the senior members of the group. And in some cases, the manuscripts have also been drafted. Also, many of the groups have been successful in registering this as a prospective systematic review on Prospero. The others also tried. In some cases, we were not successful, but we will try to get as many of these possible reviews registered on Prospero. And after this meeting, we will set a deadline by which time the manuscripts will have to be finalized and then submitted. Since the meeting is being held under the auspices of IASGO, we probably will submit these articles or these reviews to SGO, the journal of IASGO, which is covered in many indexing agencies. And I still need to discuss with the IASGO office bearers whether it will come out as a special edition of SGO or whether it will be serialized in multiple issues of the journal. So with that in mind, I would request my young colleagues who are the prospective first and co-authors of these reviews that whatever discussions happen here, please keep taking notes related to your questions specifically so that you can include those discussions in your final manuscript. And then, as I said, we will set a deadline of a couple of months for the final submission of the manuscripts. And once again, I would like to welcome all of you, those who have come from outside India and my Indian colleagues, with the announcement that the 2024 Jaipur Surgical Festival will again be the first weekend of December, 6 to 8 December. Please mark the dates in your calendar. We will soon discuss the theme and announce it. With that, I welcome you all. And then we have a pre-recorded message from Dr. Dan Duda, who is at the Harvard Medical School in Boston. He's the Secretary General of the IASGO, and he has sent a pre-recorded message. I can see Dr. Duda online, but since he's sent a pre-recorded video, I'll play it, and then I'll request him if he wants to say something else.
On behalf of the International Association of Surgeons, Gastroenterologists, and Oncologists, ISGO, I am delighted to welcome you to the third Jaipur Surgical Festival, JSF. being organized by the Mahatma Gandhi Medical College and Hospital, Jaipur, on December 1st to 3rd, 2023. I greatly enjoyed participating in person at the second JSF meeting last December, and I'm sure this year's meeting will be equally a great success. IASGO was founded in Amsterdam in 1988 as a unique multidisciplinary society with the aim of the globalization of medical knowledge. Surgeons, gastroenterologists, and oncologists are encouraged to join forces worldwide to realize the mission of IASGO. We believe that up-to-date medical practice and expertise are needed in all communities worldwide and must be made available beyond discrimination to every patient suffering from these challenging, life-threatening, and debilitating diseases. IASGO's leadership strives to implement this vision through a well-structured educational program with a truly global reach, teaching and promoting multidisciplinary collaborative approaches for treating these diseases. Friendship and collaboration are vital in carrying out the mission of IASGO, the globalization of medical knowledge. This annual JSF meeting is another excellent opportunity to meet old friends and make new friends. We commend the remarkable efforts of Professor Kapoor, who has spearheaded the efforts to implement the IASGO programs in India. Along with the dedicated organizing committee and a strong institutional support, he created one of the highest level programs, including international experts from Asia, Europe, and South and North America, and promising young fellows from the Southeast Asian region. This will lead to networking and cross-fertilization among experts at various stages of their career and diverse interests to promote further collaborative projects at an international level. Professor Kapoor has been actively involved in IASGO for more than a decade, including by participating at IASGO World Congresses in Bucharest, Romania, Vienna, Austria, Fuzhou, China, Seoul, Korea, Moscow, Russia, Taipei, Taiwan, Istanbul, Turkey, and Verona, Italy, as well as multiple symposia such as those in Beijing, Belgrade, Cairo, and Chiang Mai. Before that, he was the guest editor for a special topic on gallbladder cancer in the IASGO official journal in 1999, an issue that included experts from all over the world. Professor Kapoor organized an IASGO postgraduate course on jaundice in March of this year, attended by the IASGO president, Dr. Ender Dulungi. Mahatma Gandhi Medical College and Hospital, Jaipur launched an international study group of gallbladder cancer, ISC, GBC, online of the International Study Group of Liver Surgery, International Study Group of Pancreatic Surgery, and International Study Group of Bladder Cancer. The aim of this large effort is to produce a series of clinical consensus statements on various aspects related to gallbladder cancer. The first aspect will be taken up by ISG GBC is incidental gallbladder cancer. About 50 young faculty members have identified issues and generated about 25 questions about incidental gallbladder cancer. They have reviewed the literature, they have prepared summaries on these questions, and the summaries have been sent to a group of approximately 50 international experts who provided their opinions. These opinions are now being collated to prepare the clinical consensus statement. Many of these prospective reviews have been registered on Prospera. The first on-site meeting of the ISG GBC will be held part of this third Jaipur Surgical Festival. 10 faculty will attend in person in Jaipur, and another 20 will join online. Approximately 50 Indian faculties are also participating in person. Given its relevance and its implications, IASGO has fully endorsed the efforts of the ISG GBC. We look forward to seeing the clinical consensus statements on various aspects related to gallbladder cancer and to publish them in the ISGO journal, Surgery, Gastroenterology, and Oncology. I would like to end by welcoming you again on behalf of the ISGO to this meeting in Jaipur, a festival of the latest medical and scientific advancements in GI cancer treatment. Thank you very much for your attention, and I really hope all of you will greatly enjoy this meeting.
Thank you, Dr. Duda. Thank you very much. Anand?
Good morning, everyone. So for the first topic for today's is for the first topic, the chairpersons are Dr. R.G. Sharma. He is a professor and head Department of Surgical Oncology, Mahatma Gandhi Hospital. I would like to call on the stage, sir. And the next chairperson is Dr. Shobna Bhatia. Ma'am's So I request chairperson to call the presenter on the stage.
Am I audible? Yeah. Good morning. We are about 5 minutes late, but this is the opening session. So I would request Dr. Prashant Mathur, who is the scientist and director, ICMR, National Center for Diseases, Informatics and Research, Bangalore, Karnataka. Gallbladder cancer is an Indian cancer. We should know what the problem is, what are we facing, and we have to give the answers. The world looks at us for the answers, and we need to know first what is the burden. So over to you, Dr. Mathur.
Good morning, everybody. Thank you, Chairperson, and thank you, Professor Kapoor and the organizing committee for giving me this opportunity to be present here. When I first time discussed with Professor Kapoor about this festival, we were quite excited about IGBC, but you are still completing the study, so I don't have the best results to show to this illustrious audience. Maybe if this meeting was held in March or so, I would come with better results. But disclaimer, I am neither a surgeon nor an oncologist, so my presence here is because we run the National Cancer Registry program for India, and it covers all 97 sites of cancer, and gallbladder cancer is one of the cancers, and this is run under the ambit of the Indian Council of Medical Research, Department of Health Research, Ministry of Health and Family Welfare, Government of India. We are a 42-year-old registry in India, and we started in 1981, and today we have 38 population-based cancer registries and 246 hospital-based cancer registries, and one of the registries is in this institution also. So NCRP, or the National Cancer Registry Program, forms the backbone of cancer control in India. As per the global standards set by the International Agency for Research on Cancer, the registry collects data on invasive cancers, which are also coded by the ICD-10, ICD-03 as Behavior Code 3. So a lot of carcinoma in situ and pre-invasive malignancies are not part of the routine cancer registry operations, because the national cancer registries are supposed to address public health problems. And the notion is that pre-invasive or carcinomas in situ are not public health problems. It is the invasive cancers which are public health problems. Maybe this notion needs to be revised and changed, but till then, so I'm giving you the background to understand what and why we collect this information. In 2001 and 2, with the support of the World Health Organization India office, we did a district by district mapping of all sites of cancer based on pathology reports. And that was the first time when gallbladder cancer was mapped across the 540 districts at that time in India. And what you see here, we did this mapping of gallbladder cancer across all districts of India. And this was the first time that we realized that there is a gallbladder cancer belt in India, which runs through the northern part of the India and is also known as the Indo-Gangetic plain after the river Ganges, which starts right on the top from the state of Uttarakhand and flows into the eastern part into Brahmaputra in the state of Assam. And this was an eye-opener that time, that there is a stark difference in gallbladder cancer in India. And now everybody very comfortably says that gallbladder cancer is a North Indian problem. So presently we run 38 population-based cancer registries. To your left are the population-based cancer registries, which are located in different locations. And these collect data on a defined geographic area on all cancers. So we are able to give rates based on population denominator. Whereas the hospital-based cancer registries, these are located in various hospitals, and from here we derive more of clinical treatment and outcome data. Survival can be estimated from either of these populations. So one set of registries gives us the rates at population level, the other gives us high quality clinical information. You would wonder, we are sitting in the state of Rajasthan and we don't have a population-based cancer registry. Yes, we don't have. But about 6 months ago, we have started a Rajasthan Cancer Atlas project with the state government of Rajasthan. And hopefully in the next 2-3 years, we will be able to give you district by district mapping of all cancers, including gallbladder cancers in the state of Rajasthan. So if you look at this age-adjusted incidence rates of gallbladder cancer, these are the 28 population-based cancer registries whose data we published. So India is not one. There is a huge heterogeneity, and the color codes are for the different 6 regions of the country. And the top is the Kamrup district in the state of Assam in northeast, which has an incidence rate of almost 8 per 100,000. This is in males. Then Kachar, Delhi. And one can see that it is the southern part of the country which shows a much lower incidence rates. But in females, again the same sites or the same geographic regions, but at a much higher incidence rate of 16 per 100,000. And so gallbladder cancer is, yes, an Indian subcontinent problem with many other such LMICs, and the solutions also have to come from us. We would not expect some other countries and leaders to solve this very burning problem. And unfortunately, this has not caught the eye of policymakers in India regarding cancer control, because they are besieged with breast cancer, cervical cancer, oral cancer, lung cancer, stomach cancer, those kinds of cancers. These are the trends. So there are 5 registries which we had data for the last 40 years. And we looked at their annual percentage change of cancer. So Bangalore is southern India, the blue one. Mumbai is western. So you can look at the paradigm that, yes, it is the northern part of India which is showing in females and males the highest changes in growth of gallbladder cancer. We looked at the ranking of gallbladder cancer. So Delhi, North India, between 1988 to 97, it was on 4th in females, this is all, but now it has come to occupy the 3rd position. So in a matter of a few decades, it has jumped in rank, and it is competing with only breast and cervical cancer. But Bhopal, which is in the middle part of the country, which could be considered as a transition zone between north and south, it is at a much lower rank. And then Mumbai in western part, it was not there in the top 10 in the 1980s, 81, but now it is there. And I'm not showing, but there are now registries from Bangalore and Chennai in southern India which are showing an increase in gallbladder cancer, but their incidence rates are around 1.5 per 100,000. And probably there is a lot of need for understanding as to what is happening. And maybe in the next 20 years, this whole paradigm of North and South will be challenged. Then from our hospital-based, 96 hospital-based cancer registries in India, we published this looking at the age. The peak age in males and females remains the same. However, in females, the peak appears almost a decade before the males. Now, this is a data on almost, I would say, 2.8 million cases registered. Then we look at the clinical extent of disease. Whether it is males or females, the localized disease is just 1/4. And if you look at whether it is loco-regional spread or distant metastasis, it accounts for almost together 3/4 of gallbladder cancer. And this is the tragedy. And this is where the need for incidental gallbladder work comes in. Anecdotally, from published literature, we understand that a lot of incidental gallbladder cancer is missed. Cholecystectomies are done left and right in the northern part of India. A lot of it is not subjected to very good histopathological examination, and incidental gallbladder is missed. And these ladies, after some time, present as stage 3 and 4 gallbladder cancer. So it's a missed opportunity. And this is where the role of such organization comes in, to create that algorithms, that awareness within fellow colleagues that there is a thing known as incidental gallbladder cancer. And I think in this discussion you must have a lot of pathologists involved. Because when we set up a special study 5 years ago, we actually set up a lot of quality assurance measures, and we realized that everybody doesn't look at gallbladder cancers in the best of institutes in India very meticulously. So we have set up protocols on how the specimens should be sectioned, stained, and examined. Then we look at treatment. Now, I don't know, you all have to tell me, the use of chemotherapy, whether it is localized or distant metastasis, as it increases, use of chemotherapy is highest. And this is where you see a failing surgeon, because you don't get localized tumors to operate on. So probably you are looking at much advanced diseases which are inoperable, and so the role of chemotherapy, radiation therapy, and palliative care becomes more important. As I said 5 years ago, now we wanted to look in more detail on gallbladder cancer. What I just presented is a very overview of it. So we run a lot of studies known as patterns of care and survival studies. We have studies going on cervix, breast, and oral cancer. So we added gallbladder cancer also in this. And this is a data from nearly 30,000 cases registered between 2018 and 23. And the age distribution is very similar to what I presented earlier, that it is a much more in females at an early age. And also that almost 91% of the gallbladder cancers are around the neck body fundus, that is coded in the ICD-10 as C23 region. Majority, 41%, were distant metastasis, which reconfirms our earlier finding. And this study was done in 10 major hospitals of India, spread across the entire gallbladder belt from the northernmost part to the easternmost part. Then we looked at risk factor based analysis, and these are very preliminary results, so I don't have an interpretation, but just to cholelithiasis was present in 33% of females and 23% of men. Then you can similarly look at cholecystitis, history of infections, but there is a history of past gallbladder disease also. And these porcelain gallbladders, and there is data being collected on operable gallbladders also, which then became invasive gallbladders, cancers. This is a 3-year survival curve, overall survival for gallbladder cancer. And because we are still following up these patients for 5-year survival, and very clearly the female is at a disadvantage in terms of survival, relative survival as compared to male, and we see a lot of distant metastasis. Now when you look at stage-wise metastasis, the stage 1 offers the best 3-year survival rate of nearly 80%, whereas stage 4 gives you a survival rate of 2.8%. Now, these are some things which probably we are describing for the first time in a large sample size. And we would like to benefit from your knowledge and your wisdom, and we will certainly take up the questions which you put up to put it on an analysis map on a larger cancer registry database. So to summarize, there is a high burden of gallbladder cancer in the north and the eastern parts of India with much higher rates, and the force of cancer is higher in females with a decade earlier peak, and there are some now reported increases in incidence in southern registries also. Probably migration is a reason. People are moving across the country for education, employment, and settling down. So more studies are needed to look at this aspect. We have a huge problem of distant and advanced cancers of gallbladder, and that incidental gallbladder cancer diagnosis needs an urgent attention. So just to give you a figure, we have collected data on nearly 8,800 cholecystectomies done for benign causes, apparently benign causes. There was no pre-op indication of malignancy, and out of these 72 are incidental gallbladder cancer, which is around 0.8%, and it gels with generally what is published from India, somewhere around 0.5 to 1%. But we are still accruing that data, and we will come back. So we need better early diagnostic methods. Using these large data sets, we do hope to develop some prediction models for gallbladder cancer in terms of susceptibility, looking at risk and progression of disease to have an impact on its survival and outcome. Thank you very much for your attention, and I'll be very happy to listen to the deliberations of this festival. Thank you very much.
Thank you, Dr. Mathur. We really appreciate your work and the work the National Cancer Registry is doing in mapping the cancer pattern in the country. I know these figures seem to be minuscule as compared to the population that we have, but this is a wonderful work, and it is really very difficult. We have conducted some studies from Rajasthan, we have already published it, but I know it is a very, very difficult problem, and how to collect the data is a tremendous amount of work that you are doing. So for gallbladder cancer, we know the incidence in the northeast is the highest, and there is an alarming trend and an upswing. Females develop at a decade earlier than males. Almost 40 to 45% gallbladder cancer is seen in advanced stages, and females are more susceptible. Only 20% seen in localized stage. There was an interesting chart of treatment with chemotherapy showing the limited role surgical treatment has. Survival varies from 70% in early to almost dismal in advanced stages. Now we know that all cancers are notifiable disease, but I think it has to be implemented that the moment the pathologist anywhere in the country diagnoses a malignancy, it has to be notified. And probably that would be the simplest method of getting adequate data. So we need to tap the pathology centers involving basic scientists to find out the etiology and preventive strategies. what is the cause, whether it is environmental, lifestyle, what is there, and proper detection and treatment of incidental gardener. Any questions, quick questions or comments?
I really enjoyed that, Dr. Mathur. The question that I have for you, you showed us very nice data on different aspects. How about the socio-economic status? Does the prevalence of gallbladder cancer in people in the Indo-Gangetic belt have anything to do with the socio-economic status of the population? And this particular belt, the issues have been regarding environmental contamination, water supply being contaminated by various kind of chemicals. The BHU work points in that direction. So is that something that the registry is looking at?
Yes. So that is why I said I'm in a little preliminary stage, but we will be coming out with the socio-economic aspects, the exposures, the chemical pollutants, pesticides, as well as infections, drug exposures, some of these things. So, I mean, we'll have a larger question for India, why is this so peculiar to the Indo-Gangetic belt, not to any other river bed? I mean, the status of pollution and everything is similar across the country. Why should, and Ganges is our holiest river.
This very high incidence reported in the data from northeast, some of the districts, is it a true high incidence, or is it because the documentation they are recording there is better than other places? Because people who have worked in Delhi or North India and Southeast also, the perception as a clinician is that it is not that common as it is in North India. So is it an aberration of the data?
So, this figures come from the population-based cancer registry. And the method or work, so the team goes to the hospitals and collects data on all sites of cancer. So it's not that you make extra effort for gallbladder cancer. Okay, it's same for whether it is stomach, leukemia, lymphomas, or stomach breast cancer. And this is a consistent data over the last 20, 30 years. So we don't see fluctuations happening. That is one of the reasons to believe underreporting will be there. And cancer is, sir, not a nationally notified disease yet. There are only 16 states in the country who have notified cancer as a notifiable disease. Rajasthan is one of them. So we don't have that. So there is a problem of underreporting, but it's a systematic bias. So there is no fluctuation determined on that. A patient of Assam, Kamrup, Tripura may come to Lucknow, Delhi, Jaipur to get operated. And when you, as a clinician, you sit here, you see a lot of gallbladder. But as a registry, when I collect data from Mahatma Gandhi, I take the address. And when you give the address Kamrup, I will populate it in the Kamrup PBCR because it belongs to that. And so these rates are different from what you experience clinically.
So in other cancers, in these northeastern districts, there is no discrepancy or no difference as compared to other places?
So Northeast leads India in overall cancer burden.
That's what I was saying, sir.
Okay.
Is it better documentation?
It is proper, it is better documentation also. But if you look at the exposure rates, tobacco use today is highest in Northeast. Alcohol use is highest in Northeast. So, so these are research questions as to why is there. So reporting becomes not a question of whether you collect more data. It is question of looking at the stability of data, and that is what is the credibility of a registry, to look at the stability of data. There are no fluctuations happening.
Other is just a comment. I think we should give up, although Dr. Shukla coined that term, that gallbladder cancer is a gangetic cancer. It runs from Pakistan, Nepal, North India, Bangladesh. Ganges doesn't run through all these places.
So for India, we will say Indo-Gangetic belt. That is the only thing. It goes up to Tripura is also there.
Dr. Mathur, I really enjoyed the data. It's eye-opening that we have this data from our place. I work in Bangalore. I used to work in the northern part, Lucknow, Delhi. And we know that there is a difference in the incidence of these, prevalence of these cancers. what would be the research question would be that we know that these areas have high incidence, but there is a lot of migration now to other parts of India from this. And to make environmental factor the cause of that, would following these patients and seeing, or these people or population, and seeing that their incidence changes in that population in the different part would indirectly show that there is an environmental component in that. Is it possible to study in such a manner?
Yeah, certainly. These will be very intensive studies which will require a lot of following up of populations to document their ethnicities, their lifestyles, and measure environment. So if we know what is the environmental exposure to be measured, one can. And then to ascribe it to the cause of cancer is something to, so these are very intense studies, but yes, possibly it can be done. It can be done in a limited setting. So migration is certainly an issue. So I don't know what genetic makeup will make a role in such cancers coming up in southern part of India.
That was a great talk, so I just have one comment. Of course, the genetic component has an overriding role to play along with the environmental pathogens. There is a study that comes from UK that goes ahead and says that in patients who've undergone a cholecystectomy, the chances of finding an incidental gallbladder cancer is way higher if the patient is actually coming from India. Just wanted to make that comment.
Yeah, so that is, but within India we don't want to see IGBC, In many, unfortunately, specimens are operated and put into the dustbin directly.
I'm sure there are going to be many, many more questions to Dr. Mathur, and we can discuss over tea. So thank you very
Thank you very
much.
much.
And